is actually not on this call. She's unable to join us. She is doing a training. And before I even get started introducing this, I am going to click the start button because I have 8 o'clock and we can start recording this now. So this session will be recorded, and when we get the link, we will send it out for everybody if you want to share it with anyone to hear it and or see it. So again, this is Ray Davies. I am your session moderator. I am the IMBCO Administrative Director. Very happy to see you all here. I wanted to share with you, though, why I have this photo of Deborah here, because she does send her greetings. This photo is of her skiing in Vermont. And the interesting thing is just a few minutes before this photo, we were on a board call with her. And so I would just want to share with you the demonstration of the commitment of our board. She actually stayed on our whole 1.5-hour board call while she was on the slopes in Vermont. So that's why I have this photo up here, and she sends her greetings and apologies for not being able to join us at this time. So I am going to move forward to Mercy in Action's presentation in hopes that everybody who is going to join us will be able to join us. I know it takes time to get all connected on board. So I will actually turn this over to Vicki now. And Vicki, you can decide if you want to wait a couple more minutes. There are many more people that were going to join us that I see aren't here yet. But for those who are here, it might be nice if you get started. So I will let you decide, Vicki. I'm turning the mic over now.
Okay, so can everyone hear me okay? We can go ahead and start with a little bit of introductions, if that's okay. What we're going to show you today is actually a teaching that we based on the IMBCI 10 steps. Okay, I can talk a little bit louder. I'm on a laptop, so I'm hoping my mic will work. Is that better? Can you hear me better now? I'll wait to see if everyone says yes, that you can hear me okay. All right, I hope this will work. This teaching set of slides you're going to see this morning is based on a patient teaching that we put together in the Philippines for the women having babies in our birth center. And so keep in mind that if you were actually watching this, it would all be voiced over in Tagalog, which is the local language. So we did the text in English following the 10 steps of the IMBCI, but we had it voiced over in Tagalog. And you'll recognize the text and the layout of the slides because they are the IMBCI slides that are on the IMBCI website for everyone to use. But what we've done is we've put in local pictures of local women. So all of the pictures are of our community, and in that way we've personalized it just for that community. Yes, you will not hear the voiceover in Tagalog. The reason I'm telling you that is because one of the 10 steps is to have all the information available in the local language. So for today, I'm just going to be talking about each of the slides. But if you were actually in our birth center, you would see this playing with voiceover in the local language. So with that said, we can switch to the next slide, I guess. This is some of my credentials. I have studied not just midwifery, but other cultures for my entire life. I do live in the Philippines full time, and there are 4 generations of our family living all together in one courtyard now. So my husband, his mother, our son Ian and his wife Rose, who are both licensed midwives, and their 3 children. Our work has been featured in Robbie Davis Floyd's book, Birth Models at Work, if anyone wants to study it more. And since 1991, we're up to about over 12,500 babies that we have delivered free in our centers. So we're outreaching to the poorest women. Okay, so what we'll do is just jump into the slides, I guess, and start sharing how we present. So this is the first slide that somebody would see when they start the presentation. Okay, don't go too fast here, but yes, this is the next one. We put at the bottom here, so to personalize this slide, we put that we're proud to provide all 10 steps to the women who give birth in Olongapo. So you can turn to the next picture now. I wanted to say something about how we present ourselves in the community. There's a picture of our wall. So we use a slogan from our local mayor, which is fighting for excellence, and we incorporate that in. And then in everything that we have done in Olongapo, since setting up this newest of Mercy Nation's birth centers, is to present ourselves as a site that is using the 10 steps of the IMBCI. And it's an important way that we presented ourselves to the Department of Health in the Philippines. And it is how we have avoided a lot of cultural problems with people saying, oh, well, maybe that's how midwives do things, or maybe that's how they do things in North America, but that's not how we do things here. And I just wanted to say that I encourage anyone that's working in a cross-cultural setting at all, or working anywhere, the 10 steps have a very powerful way of holding your center to excellence and to high standards, but also protecting you from outside interference in the birth process. And one example was that the doctors in our local area put a lot of pressure on us, wanting us to cut episiotomies, and because that was their standard of care. There was a lot of pressure for things like that. So by using the 10 steps, we were able to sidestep that without it becoming a personal battle between, philosophies. It was, well, it's, we follow the 10 steps, and that isn't a evidence-based practice. And we've been able to use that many times to keep everything cultural, appropriate, and yet not have to get into the discussion of, you don't do episiotomies, but we do. And so, yeah, I just wanted to mention that. It's been really, really helpful to use the 10 steps. Besides just, it keeps us natural, but it also keeps us outside of excellence. Okay, so you can go to the next slide. Okay, and we'll start. This starts here with pictures in our birth center. Everything you'll see will be local women. And I think that's really important because the generic IMBCI slides show women from all over the world, but we wanted to demonstrate to everyone today how you could put your own pictures in and then make it very, very real for your community that, oh, these women look like me, these are my people, this is for me, this isn't for Africa or Thailand or somewhere else. So this slide just talks about what the IMBCI is, what it focuses on, and facilitating normal birth, supporting breastfeeding, and avoiding unnecessary interventions. Okay, next slide. This is a little bit of the history of IMBCI, and Ray and Elena helped us put this together. How to point out to people that, again, this wasn't Americans coming up with this. There was 163 different countries whose organizations in some way gave credence to this or answered a questionnaire supporting these 10 steps. And so, again, on a worldwide level, we're doing something that is way bigger than just Mercy in Action in the Philippines. It's way bigger than just one group or one nation saying this is the way to do things. So I think it's very, very important when you use these steps to stress that this came from a much, much, much broader base, and that in some way a lot of different countries had a say in this. Okay, go to the next one. We changed this heading just a little bit to make it world famous organizations. Again, this slide has helped us probably more than anything in getting the local doctors to accept our birth center, our site, is that some of the really big names everyone knows, WHO, UNICEF, UNFPA, have also been somewhat a part of the IMBCI in some way, giving it credence and acknowledging these 10 steps are important. So in order to, when you go in with something like this in a community that's used to birth either being, well, usually birth being very interfered with, but also not having high quality standards for it, this is important to explain what IMBCI is and how many other groups have looked at it and said, yeah, this is good. Okay, next slide. And of course, in our area, safe motherhood is a really big deal. Philippines has the dubious distinction of being one of the countries in the world where maternal mortality is going up right now. It's not going down. As of the newest report this July, it went up significantly. So we are really stressing that we're working with the WHO Safe Motherhood Initiative. We're really stressing the baby-friendly part, and especially we're really stressing that Mercy in Action, through using these 10 steps, is working toward achieving the UN Millennial Development Goals 4 and 5, which are to reduce maternal mortality and reduce neonatal mortality. So we're always coming back to that. Again, when anyone says, well, we do things differently, we always come back to what are our goals. Our goals are safe births and good outcomes and living mothers and babies at the end. Okay, next one. And this is a picture of our gate. So we start out our presentation for the mothers by saying welcome. So all of the rest of this now is really speaking to the women themselves. These slides and these voices are talking straight to them. I want to just give you a little bit of background on who our mothers are. We do outreach to the poorest of the poor. So we have 3 main communities that we outreach to. One is right on the road we live on. We're right on a river on the edge of a town. We have a large landfill. It's a giant garbage dump. It's like mountains and mountains of trash that squatters live right on the garbage dump to make a living from, picking through the trash. So that's one of our groups, and the other is a resettlement camp where people are internally displaced refugees from a natural disaster many, many years ago. And then the third group we outreach to is just all of the poor that live along our road. So these are not real sophisticated women, but they're women that care about their babies and care about good outcomes. And so we've tried to make the 10 steps very simple for them to understand. And like I said, as you're seeing these, imagine they're hearing this in their own, they're hearing all this in their own language. Okay, next picture. Here's our group of midwives and myself. So we have a lot of pictures of the caregivers that will actually be taking care of them throughout these 10 steps. Okay, next slide. Step number 1, treat every woman with respect and dignity, fully informing her, involving her in decision making, and providing the care in her own language. So that's why it's important that I stress every now and then that when women watch this, they're seeing it in their own language. I have been in a lot of birth settings in dozens of countries, and this step number 1 is one of the hardest ones. It's very painful to see that this is rarely met, and that when centers, hospitals and birth centers and even midwife home birth practices don't meet this, they're rarely aware of it. I think that's one of the really, really important things that we can do with IMBCI. And with the new grant that USAID just gave to try to promote through the White Ribbon Alliance and others, the respectful care of women. But there is very, very little true dignity, respect, and informed consent going on. So we're very proud of step 1. We work really, really hard at this, and I think we're doing a pretty good job of it, but it's always something we can all do better on. But yes, I think step 1 is one that other people just pretty much skip over, and they want to look at more physical things they're doing, but this is a big one that's usually not achieved. Okay, next slide. What we do here is now we're adding a little bit to the IMBCI slides, and we're telling people a little bit what their care will look like. So we're telling women here that the new international standard best practice for prenatal care is at least 4 checkups. They're calling it focused antenatal care and very thorough checkups. So we'll talk about that in a little while. Go ahead to the next slide. And here's a woman that is on a scale, but you see behind her a poster of fetal development. So the women are absolutely thrilled to be taught about their bodies and how it's working and how the baby's developing. And you can just see them light up with this information. Some of them have had 8 babies and never had any idea of how some of these things work. So it's very fun and exciting on prenatal days to be doing education. Next. One thing we do in Mercy in Action, because malnutrition is such an issue for us, that we have a vitamin campaign where people in the States buy us prenatal vitamins and ship them over, and we give every woman prenatal vitamins. The other thing we're doing, and it kind of fits here, but it kind of fits later in the slides too, under number 8. We give everyone deworming medicine because parasites are such a big problem in pregnancy where we live. And hookworm is responsible for so much anemia. So we're just preparing the women here of what we're going to be giving them when they come for their prenatal care. Next. Step number 2 is possessing and routinely applying midwifery knowledge and skills that enhance and optimize the normal physiology of labor, birth, breastfeeding, and the postpartum period. So each of these, when we come to the steps, is straight from the IMBCI site. Okay, next slide. So we offer midwifery care, and we're always training others. So we let the women know that they'll always have student midwives with them learning. We make this fun for the women, and no women complain about this because they get a lot more attention. So we try to make the fact that we're training people be a real special thing, and I think usually it is. Okay, next slide. And there's a picture of some of our midwives. They're there to serve them and help them have a safe and happy birth. Just the whole attitude of having midwifery care that is loving and warm is a new concept in the country. And so even when we train the midwives that have been trained in the hospitals first thing we have to teach them is to smile, is to be compassionate, and not just do the physical steps of checkups. Next. So here's one of the midwives doing newborn care, and we'll talk about this in another slide, but you can see there that the baby's cord is not yet cut, even several hours after birth. Okay, next slide. And immediate breastfeeding is a big part of what we do, so it'll show up through these slides several times. At this point, we're averaging about 12 to 15 minutes. All babies are latched onto their mother, so we're very proud of that. We're doing better and better on that just by not interrupting birth. Okay, next slide. Step number 3 is to inform the mother of the benefits of continuous support. Now, when I've talked to some other sites in the Philippines that would like to do the 10 steps, this always trips them up because they say, well, we physically can't make room for the mother to have a companion. So that's one of the big issues I think that hospitals and birth centers are struggling with. But it's one of the steps that I think means the most to people. Okay, next. So we make it very, very clear in our teaching. Remember, this is the prenatal teaching the women will see every time they come in, that they can bring a family member and that the husband can be there, the mother. People are not used to this in our culture in the Philippines. Nowhere else are they able to have a companion. So it's a very new concept. They're used to the idea of bringing a companion, but that companion stays outside the room and is who runs to buy medical supplies, because in hospitals you don't get medical supplies unless you have a companion that goes and buys them. So for us to tell them, no, you can come in, you can be with your wife or your daughter, it's quite a big shock. So we really stress that during our slides. Right, next picture. And we talk about what the companion is there for, because they think the companion is there to run and go buy an IV or to go buy a cord clamp. And so we stress again that, no, your job is to comfort and assist the mother and stay with her throughout the labor. Next. So here we talk about also bringing a female companion as well as the husband. And this is based on, because one of the 10 steps is to do everything evidence-based, we've looked carefully at the doula studies that were done years ago that showed that every area of complications was lower if the woman had a female companion. And so we really stress that she bring a female companion as well as the husband if he's available and wants to be there. Okay, next slide. This is a lovely picture just moments after birth. And so again, we're trying to build into a culture that's not used to birth being nice at all, and they're definitely not used to having a husband or a loved one with them. So we're building in that that's one of the most positive benefits if they birth in our center. And of course, they're not separated from their baby. Okay, step 4 is providing drug-free comfort and pain relief methods. Again, this is one I don't think a lot of people understand because I've been in hospitals that are trying to meet the 10 steps, but they think they've already met this one because they don't give any drug relief. They don't give any drugs, but the women are poor and they don't get drugs because they don't have money to buy them, but nobody really understands how to support a woman who's not using drugs, how to help her not be in pain. So I think this is an important step. It's not just drug-free, but it's giving comfort measures. Okay, next. And here you can see the husband is rubbing his wife's lower back while she sits on a birth ball. This all has to be trained in, of course, because it's not part of the culture, but it's not hard to do right at the time. Just teach the father of the baby how to be helpful. Next. Being able to eat and drink, I think that's something we've had a long time in North America, but other cultures still deny the woman food and water. So this is all part of how we prepare them of how they're going to be treated when they come in labor. And this is a happy woman in the late stages of labor, eating some noodles and having a drink. Okay, next. And this is a very lovely slide about just showing them that they're going to be treated with love, comfort. We're a faith-based center, so a lot of times the midwives will ask if they can pray for a woman. And you just see the happy look on the mother's face that this is different. This is different kind of treatment here. And so we stress that, and then we try really hard to be very loving and comforting during her care with us. Next. Step 5 is to provide evidence-based practices proven to be beneficial to support the normal physiology of birth. And boy, do we work on this. We are reading studies, several studies a day. We're constantly weeding our way through studies, looking at what's the best way to do things, the most evidence-based things to do, constantly adjusting that for our low resource setting and our poverty setting. But it's something that's very important to us, and so we really stress this slide. And of course, as you all know that are familiar with IMBCI, that the Step 5 has many parts, so we'll go through some of them. The next slide. Okay, so this is one of the IMBCI slides about supporting the mother to walk, assume the position of her choice, and providing tools to support upright position. So a few of our local pictures, the mothers do walk around, usually till the very end. They're allowed to assume any position they want. Our culture where we live, the women have been disempowered for quite a lot of years, and even at home births, they're usually made to lay flat on their back, and then someone gets up at the top and pushes the baby out, bundly. So it's a little bit different to tell them, no, you can squat, you can stand, you can do what you want. This picture doesn't show it, but we also have a tub, and we also have cloths hanging from bars that they can use to pull themselves up like a rope. All right, next picture. Oh, there's our tub. Okay, so this is our birth tub. No, we have a brand new birth center because we had a devastating flood last August, and so we built on higher ground, and so we were able to build a beautiful built-in tub. You see the hot water heater there to heat it. We have a birth stool you can see in that picture. and then a woman using the birth ball. What doesn't show is that we have a thick hanging cloth for them also to pull themselves up with. All right, next picture. Practice is proven to be beneficial is also immediate skin-to-skin, breastfeeding, and stimulation, ensuring the baby and mother stay together. That's just a given with us, but we've learned over the years that the way to get babies to breastfeed early is to keep the third stage of labor also very quiet. We keep second stage very quiet. People don't talk. We let the mother give birth very uninterrupted, but then we've kept that for the first half hour after, and we found that babies will latch on and start nursing some as early before 10 minutes. And as everybody knows, you can't make a baby suck, so you just have to make the right conditions to where they'll do so. But the skin-to-skin for warmth and the early breastfeeding is one of the biggest survival issues of babies where we live. Okay, next slide. The other thing that we started doing, and we set up this picture because usually we have the placenta covered and the baby covered, but one of our big motivations for waiting to cut the cord, not just a few minutes, but actually a few hours, is to prevent the risk of neonatal tetanus. And so even though we have an autoclave and we have sterile scissors, we are doing this practice to model to the community. There's still over 50% of the women in our community will give birth at home without anyone helping them. Still a lot of rural births up in the tribes where the grandmother or a traditional midwife will cut the cord. And so we want to model for our community how to prevent tetanus. The tetanus bacteria is a very large bacteria, and after a few hours after birth, the cord has atrophied down so much that that bacteria can't pass, and it's not as important how clean the cord is cut. So as most of you probably know, there's been huge emphasis in the last few years on having clean cord cutting, and people are putting a lot of money into sending out little cord kits and all these things. If we could just teach people to wait 3 or 4 hours, and then it wouldn't matter what you cut the cord with, we would cut down this terrible death rate from neonatal tetanus. So that's our practice now in our birth center, and it's also had a very happy side effect that nobody takes the baby from the mother. Oftentimes in the past, family members always wanted to snatch the baby to hold it instead of just letting it breastfeed, but now they nobody wants to pick up a newborn and a placenta, so the mothers really sit there for 4 hours and just nurse their babies. It's really been wonderful. Next. Okay, so we tell the mothers here, and here you can see a baby with a cord, and we also give babies vitamin K injections and give them a full newborn exam. So we're preparing the mothers for what to expect when they have the baby. All right, next. Now we're going to get into the potentially harmful slides. So this picture was actually taken in the large Philippine hospital in Manila, and you can see how many babies are overcrowded there. We talk here about when there's a specific situation, we will use an intervention, but the benefits have to outweigh the risk, and none of these things are ever done routinely. So this is a key, like I said, to helping us when we get pressure from the medical community to do things that we know are not evidence-based. Okay, next slide. I think we have a disclaimer on the next slide. Yes. So since we're showing this to the mothers, and so far all they've seen is women that are delivering in our birth center, we have to tell them here that none of these pictures are ours. Now these are pictures that we left, the ones that IMBCI found, of bad practices. So the next pictures we'll show will just be examples of harmful practices we do not use routinely. And so at the beginning of every one of these slides, they hear in Tagalog, these are harmful practices we do not use routinely unless there's an indication. So, of course, IVs, keeping the mother in bed, withholding food and water. Okay, next. Of course, the flat on the back in stirrups or caregiver-directed pushing is harmful. So they get to see these very graphic pictures of what we don't do. Next. And here's the really hard pictures to watch, and it always gets people talking because they're used to these things. And even midwives, licensed midwives at home births do both of these things. It's very common to have episiotomies and fundal pressure at a home birth where we are in our area. I know that's not true everywhere in the Philippines, but it has become true where we live. So by showing these very graphic pictures and telling women this is potentially harmful, we're opening them up to a whole new idea about birth. Next. Suctioning of the newborn and immediate cord clamping. Of course, I was glad to see that suctioning got on the list IMBCI made, because that has now been proven not to be beneficial if the baby is breathing. And so these are things that we're just sharing with people we won't be doing. Next. Medical augmentation of labor with Pitocin has become very common even in low-resource areas like ours, and even at home deliveries. People will speed up the labor with Pitocin. So we left in this very graphic picture showing, and also the very graphic picture of someone with their hands inside the woman's vagina while she's pushing. And unless there is a complication, we don't actually touch the woman's genitals at all while she's giving birth. We have found that we have less tearing if we don't try to prevent tearing, and we just don't touch the woman's genitals. So the births with Mercy in Action look very, very different. We also don't take pictures of the actual birth, so we can't really show you, but it would look very different than this. Okay, next picture. And of course, we don't routinely separate the mother and baby. So these were all pictures courtesy of the original IMBCI slides. They're good pictures. Thank you. All right, we're on to step 7. Now, step 7 is very, very important if you're in a third world setting, and it's one of my concerns that everybody that is in the kind of low resource setting we're in would be doing the important things to enhance wellness and prevent emergencies, because we are in an area where a lot of mothers and babies die. So I think a lot of times people focus on just the natural part of birth and don't focus on the fact that we have to prevent illness and death. It's very, very important to what we do. So here you have a picture of monitoring. Having good blood pressure monitoring cuffs is something they found to be a real downfall in a lot of hospitals or birth centers. They just simply don't have working equipment, and so therefore they can't find the hypertensions and the preeclampsias. All right, next slide. This is one of the tribal mothers that we've worked with in the past here, providing education and access to methods of disease prevention. So malaria, we do have malaria test kits we can use. We are testing all women for HIV/AIDS and are prepared to treat with antiretrovirals, because we're in an exciting era where we can now prevent mother-to-child transmission of HIV/AIDS. Same with hepatitis B. 1 in 10 women in our setting have chronic hepatitis B that they will pass to their baby unless we test for that and treat. So we're testing not just HIV/AIDS. Now, this text is straight from the IMBCI slide, but we would add Hep B, especially in an Asian context. And then the tetanus toxoid immunization is extremely important to prevent neonatal tetanus, but also the mothers can get tetanus from where they give birth. If they give birth, of course, tetanus grows in dirt and in animal dung. So in cultures where they're delivering in a barn, or whether they're outside or have a dirt floor, it's incredibly important that they're immunized for tetanus during their pregnancy. So those are some of the things that are a little different from North America that I was very, very thrilled to see IMBCI put in their slides. Next. So here again is a woman in our center getting ready to get her blood drawn to test for Hep B, HIV. We're also starting to routinely check for syphilis. And if she is in a malarious area, we can check for malaria. We have a rapid test that actually tells us which kind of the 4 kinds of malaria someone has. So that's particularly brilliant. And we buy all those rapid tests and have them no charge to the patient. Okay, next. Now this is a picture of our local landfill, and you see one of the women out there with her child, and they're digging through the dump. And then the other picture is of a woman and her child that live right there on the garbage dump. So just to visually show that we need to give tetanus to all these people that are living in those conditions. They're walking barefoot or with flip-flops through that kind of garbage situation. You can see why the tetanus is very important. Okay, next. Here you see someone sitting on the floor of our waiting room looking through the 10 steps of IMBCI. What we did a few years ago was print it from the slides, and then my husband helped me put it in a book. So this was years before we made this presentation, so you'll recognize the pictures from the actual IMBCI slides. But women sit in the waiting room and look at that book as well as watch this this talking video show that you're watching. Next. Okay, and the next step is to measures that enhance wellness and prevent illness is, of course, to support prenatal, postpartum, and newborn care within the family context and the community environment. So that's a very important step. Next. So here we're just showing that we're trying to keep everything clean. We actually have the husband's help with the laundry after because he's the one that shares body fluids with his wife. So if someone besides the husband rinses out the initial bloody sheets, then we have them wear gloves. Cleanliness is a real problem in a lot of settings. So this step would also address that whole issue. I think we talked on the phone one time about how do we put in some of these things like cleanliness, but it's already there as long as we just realize that that step of enhancing wellness includes always making sure that everything is sanitized, and that's a real problem, I think, in a lot of third world settings where women just climb onto a bed that still has blood from the last patient. I've seen that in so many different settings in so many different countries that it has ceased to shock me, but we should still be shocked. We need to make sure things are clean for mothers. That's just elementary. That is why women used to die in our country 100 years ago. Okay, next slide. And then the home visit. So we put our home visits under this section of enhancing wellness in the community. Again, we're quite unusual in this for our setting. We go to at least 2 home visits at 24 hours and at 3 days, and then we'll go every single day if the baby is low birth weight or has any abnormalities like a cleft palate that might make breastfeeding more difficult, or if the mother, we're treating her for an infection or something like that. So home visits is a big part of enhancing wellness in the community, and it also gives the community a real visual picture that the midwives are concerned that they're there. They're not just staying in their center. They're involved in the community. They care about these poor mothers and their babies, and it really adds puts a lot of value on that new family. Okay, next. Step 8 is to provide evidence-based skilled emergency treatment for life-threatening complications. So again, I'm so very, very happy that IMBCI put in step 8, that the focus, I know the focus on the mother-friendly was mostly how to keep birth natural, and I think that's incredibly important. But when you're in a low-resource setting, you're in a developing world country, it's very, very important that people that are providing the 10 steps also know that they're going to adequately respond to any emergency, because we can lose mothers and babies so fast. In this picture, you see that the mother has an IV in, so she has hemorrhaged after birth, but she's still there with her baby. So we try to deal with complications and still keep the families together, except in the most extreme cases. Okay, next slide. This is an anti-shock garment. It's a non-pneumatic anti-shock garment, which is a new kind of development that's being tested all across the third world. There's a doctor in Stanford University that has been doing programs all over. We're in a clinical trial with her. But these are, it's a very safe and very low-tech way of helping a mother after she's hemorrhaged. It is like a giant wetsuit with strips, and you're just shunting the blood from the legs and the stomach up. But they're very safe. They're different. They've been redesigned from the old military anti-shock garments that you blew up like a blood pressure cuff. These are very safe. Anyone can use them. They're very cost effective because they can be used over and over. And so they really can save a lot of people's lives. So we use those in our center. And here again, you see the woman who's in the shock garment. She's got an IV in, but she's breastfeeding her baby. So sometimes we put these on, women will come back to homeostasis on their own. Other times they need to go and get a blood transfusion in a few hours, but it's a stable transport, and they have been able to nurse the baby for several hours first. Okay, next slide. We do have oxygen you see in the background there and resuscitation equipment if we need it. So in these slides, we're telling the mothers what we have to help them if they should have a problem and how we're meeting step 8. Okay, next slide. This shows that sometimes we use emergency equipment, but it's not routine and it's not common. So we can use IVs, we can resuscitate babies. We do have a vacuum extractor for fetal distress. We don't have very many stillborns at all in our center, although it's very common in the rest of the country, because we monitor heart rates in second stage and we can get babies out quickly if they start to die in the birth canal. So we show people these things just to know that we have them, but they're not common at all. They are not routine in any way. So that's how we're dealing with step 8 and the other steps, just by everybody is trained in emergency skills, but everyone knows when's the appropriate time to use them and would never dream of using them in any kind of a normal labor or just in case. So again, I think it's rare for a center in a low resource area to have that clear demarcation that we do have emergency equipment and skills, but we're not going to use it for normal. And that's a very important part of the 10 steps. Okay, next slide. Step 9 is to provide a continuum of collaborative care with all health providers and other institutions and other organizations. This picture is showing one of the tribal families that she lived way, way, way up in the mountains. It was during the time of the floods in the High River, so she came to live in our maternity waiting homes for a while. I think I have a picture of those next. No, I have our ambulance next. Okay, so if an emergency arises, we have an ambulance, and so we're telling people we will take them to the hospital if they need it. We have a memorandum of agreement with our local hospital that we will bring emergencies to them, and in return, when they're too busy and have normal labors, they bring them to us in their ambulance. So we have kind of ambulances going both ways between our center and the hospital. And this shows the ambulance going out to the community. Go back one slide. I was going to talk a little more about the maternity waiting homes. Also, we have built on a piece of land very close to our birth center maternity waiting homes that women can come and stay in while they're waiting for their birth if they live very far out in the rural mountains. And so that's another one of the ways we're meeting step 9, to have collaborative care and to be able to meet a greater need for reducing that barrier to services for people. So it was my daughter-in-law, Rose, got us a grant to build the maternity waiting homes, and they have served families well in emergency situations or just in getting the rural women closer to give birth in a safe place when the time comes. All right, next slide. Is step 10 to achieve baby-friendly hospital initiative. Step 10 is the same. At the end of all the 10 steps, we have to be baby-friendly, which has its own 10 steps. And so our center is baby-friendly. And we, like I said, I'm really proud of our breastfeeding statistics, because over the years, babies have started nursing sooner and sooner and sooner. And we know we can't make a baby latch on and suck, but we know we can provide the right circumstances. So we have learned over the years, and by trial and error, how to not disrupt a newborn and mother, and to make all the circumstances right that that baby will latch on. And we record that in every single chart, how many minutes it took the baby from the womb to the breast. And I'm sure many of you watching this are familiar with the the Ghana study and the Nepal study, there were huge studies. Combined, the two were over 30,000 healthy newborns, and they showed that we could prevent 22% of all deaths if all babies drank colostrum in the first hour. So we're really, really pushing to keep that first hour very protected so that all the babies will drink within the first hour. And almost every single baby that's born in our center is breastfed by an hour. So that has to do with the practitioner not interrupting anything. Okay, next. Here's a picture of a brand newborn baby nursing. We talk to the women ahead. They're not used to this. So in hospitals, they sometimes are given the baby skin to skin, but usually not encouraged to breastfeed. At home birth, usually someone takes the baby, washes it, dresses it, wraps it up in a bundle, gives it back to them some hours later. So in the culture where we live, whether it's a hospital birth, clinic birth, or home birth, the women are not at all used to breastfeeding their baby right away, sometimes not for hours or days. So we stress this in our slides. Next picture. Okay, so we're coming to the end here. The optimal mother-baby model of care implemented in these initiatives will promote health and well-being of all women and babies, setting the gold standard for excellence and superior outcomes in maternity care. And this same set of slides is what we show to government officials, to the heads of the departments of health, to other doctors and midwives. And so we are using this as a gold standard, and we are teaching it and sharing it around the nation as we get an opportunity to share the 10 steps and how we do believe that they're optimal care, that it's not just, this isn't something strange that we're doing because we're foreigners. Okay, next. Okay, now this is another disclaimer in our show. We don't actually take movies of our patients giving birth. That's very important because the Filipinos would be quite shy about that, and it would really go against their culture. So we wanted them to see some visuals of women giving birth naturally, but we didn't want to make them be afraid that we would take pictures of them. So we gave this disclaimer, and we have a few short movie clips from Brazil, Spain, and South America. I don't know if they're going to work on this, but let's give them a try. If they do, they do. If they don't, we'll skip right over them. So go ahead and go to the next slide. And I don't know if there's something you have to push to make this play or not. Is there a button that shows up next? If not, this is just a picture from Spain of a woman laying on her side having her baby, and she pulls it up with her own hands. If you see a way to push a button and make it play, go ahead. If not, we'll just skip over it. All right, just skip to the next slide then. So we talk about the side-lying birth and how it's so gentle because it helps open the pelvis up and give oxygen to the baby, and the mother reaches down for her own baby. That's something else we're really encouraging the women to pick up their own babies when they're coming out or being born. Okay, next one. Probably won't play either, but this is from the Birth in the Squatting Position movie. So we show an actual baby coming out with the mother in a full squat. Some of the women really laugh about this because they thought it was bad to give birth in a squat. They thought they'd get in trouble. They thought that was, you know, tribal or only for, they're so used to that being looked down on that we had to show visuals for them to realize that that was okay and healthy and good. And again, in this little clip that we show, the mother herself reaches down, picks the baby up to her breast, which is what we're encouraging. So these movies aren't working, but they're just very short clips of birth. Okay, next slide. And we talk about, see how easy the birth when the mother is upright. We really do have a lot of disempowered women that we're helping, and they really do believe you have to lay on your back and someone has to hurt you to push your baby out, that someone has to shove it with fundal pressure and somebody else is going to cut you down below to make the baby come out. So I think the visuals are important. And we talk to them about how they can give birth on our birth stool or squat with the rope, or we'll help them. That's important. Okay, next. The next picture is a woman having a water birth, which again has not been cultural in the Philippines until real recently. Now some of the bigger hospitals, the private ones in Manila, are having water births. People love to see this water birth picture. It just blows their mind, and we have actually now had a water birth in their new center. So I think it's going to become more common. And this woman has her baby and then lifts it up to her breast in the water. Okay, next slide. So we talk about how the warm water takes away the pain, and we take the pressure off to have the baby in the tub. We tell them just get in during the hardest part of the labor. Get in there to take the pain away, and if you want to get out and have the baby on the bed, that's fine too. Okay, next. And then we are coming toward the end here. We just, in our slide now, says please feel free to talk to us about anything you saw on the slideshow. We know that a lot of the things they saw on these 10 steps are radical new ideas for them. And so we are inviting them now to just talk to us. And so more and more we've been seeing that happen, that these slides of the 10 steps, especially since they were put into their cultural context, is really opening up dialogue, and the women are starting to feel empowered to ask questions and to have ideas about how they want their birth to be. And so it's been really exciting to see those kind of dialogues going on. All right, the next slide is the last one that the mothers see. So this is a big thank you to the mothers for just watching. And then the next slide is our credits, who did the voiceover, where the photos came from, and special thanks to all the women who gave birth there. So we are very appreciative for all the people that helped us make this. And then the last slide that I have before I turn the mic back over, this is a picture we took just a week or two ago. This is our 4-generational family that is working on safe motherhood and bringing these 10 steps to Olongapo, Philippines. So we'll see how long it'll take for those grandkids before they're doing this work in the future, if it happens. No pressure. So that's our little story, and I can answer questions. I guess, do I turn off my mic now? Maybe Ray, you can tell me if I turn it off so I can hear others, or will people, if they have questions, just type them in?
Oh, Vicki, this has been absolutely wonderful, and I know I speak for every participant that was hearing it. Excellent, excellent, excellent. I am so impressed and thrilled to see this presentation and the use of the IMBCI in this way, and you have just absolutely proven how every step can be used and why it should be used. So I'm overwhelmed and overjoyed by your presentation. So thank you, thank you, thank you. You do have some questions in the text box, and they begin with Dr. Huber's question. Dr. Huber is in our Austria site, so he asked a good question, and then they continue to go down. So I'm going to turn the mic back over to you, Vicki, so you can answer those questions, and then I would suggest giving others the opportunity. Maybe they want to ask questions through the mic, but if not, everybody continue to text. Thank you.
Okay, I see the questions now. Thank you for telling me. I'll scroll down. Yes, vitamin K we have researched intensely, as we research everything intensely, and actually found that the particular type of hemorrhagic disease of the newborn that breastfeeding babies are more likely to get is a late type, which the oral vitamin K doesn't really address. And since all our babies are breastfed, we have researched out, at least for us, we've found that we would rather use the IM injections. We have had a baby over the course of the 12,000 or so that did have hemorrhagic disease. So, and it is a standard of care in our area, so we're following it. But yes, we have followed with interest the whole discussion about oral or injectable vitamin K. What about the management of third stage? That's a good question. Again, we're using the best evidence that we have of how to prevent hemorrhage. Hemorrhage is the #1 cause of death throughout the developing world, and it's a very, very real risk. We have very malnourished women, so we have had to come to some peace about using oxytocin in the third stage of labor. However, my daughter-in-law Rose was able to find some new research lately that found that one oxytocin shot and then waiting for the placenta naturally actually has as good of or better outcomes than full Amstel using cord traction. So that's what we're doing now, is we're giving one shot of oxytocin after the birth and then waiting for the delivery of the placenta. Now, if the woman begins to hemorrhage in third stage, obviously we move into getting the placenta out using the steps of Amstel. So in everything, we're having to balance this thing of doing natural births but being prepared to deal with emergencies, because we do have a very high-risk population. And we balance that by being as natural as possible when birth is working, and then we quickly correct any complications that happen. But as soon as we've corrected them, then we go back to as natural as possible, as quickly as possible. And then, let's see, Nora asked me about philosophy. Could you send references for the Nepal and Ghana colostrum trials? Absolutely. I'm telling everyone about these studies. I'm shocked that more people don't know about them. The American Academy of Pediatrics published the Ghana study, so if you went to aap.org and typed in Ghana, you'd probably find it. If somebody wants to write to us, if you want to go to our website, mercyinaction.org, and write to me, I will personally send you a link to both the studies. The Nepal study was published in the National Institute for Health journal. How busy is your center? Okay, in the past we've had centers that were as busy as over 100 births a month and still did this philosophy and type of care. Right now we started a new center a few years ago. It's probably, I guess we're exactly 2 years old now. It's about 20 births a month, so not as busy as some people. And we do realize limitation on buildings and things like that. But we're very, very fortunate that after our flood, we were able to build a place that has quite a lot of nice privacy for the women. Like everywhere else in the developing world, we use curtains. We don't have solid walls and huge space, but we're able to give privacy. Can we have access to the presentation? I have no idea how to do that, but my husband is on here. He probably does. What do you do about contraceptive? Oh, that's very good. That really was left out of these slides. We teach natural family planning to everyone, and we give a set of cycle beads to everyone that delivers there. So that's the culturally appropriate family planning in our country, which is largely Catholic. So yeah, that is one of the steps. I think it's step 7 or 8 to provide culturally appropriate family planning information. And yes, we do that. Do we do VBACs? Yes, we do. We don't really turn away very many people unless they're having an actual problem at the time. In other words, it's now considered in centers like ours best practice to know how to do whatever, but only refer if you have actual complications like hypertension or bleeding going on. But VBACs and breaches and things like that, we're delivering in our center. Yes. Of course, with VBACs, it's the higher risk is the women that have had more cesareans, so they have more uterine scarring, not so much for the birth, but for the placentas. Okay, so that is all the questions that I see. I'll turn off my mic for a minute to turn it back over to Ray. Okay, I'm turning my mic on a minute because I see you publish statistics, and I want to answer that. The answer is yes. Our statistics are published in the book Birth Models That Work. That was edited by the medical anthropologist Robbie Davis Floyd, and so we have our statistics published in there.
Well, that's perfect. Thank you. And of course, Robbie Davis Floyd is on the IMBCO Board of Directors and was very instrumental in the development of these 10 steps that you so wonderfully use. I'm very impressed. Again, thank you so much, and I see that there have been many thanks and now some more questions. So I will turn the mic back over to you.
Oh, okay. I see that even in Canada they don't allow women to eat and drink. Well, that is really sad. Somebody asked about our statistics, and I did write the name of the book. It was Birth Models at Work, if you want to see more. In particular with epidurals, let me see. Let me not miss any questions. Oh, okay. I see. Oh, and we have someone from Madagascar that is putting together a birth center right now. And I asked them to come on to this talk. It looks like they're on. They're trying to. This is also foreign to the population of Madagascar, and so every time someone tells me we're trying to start a center like yours, but nobody understands, even the midwives, nobody understands what we're trying to do, and I always point them to IMBCI and say, use these 10 steps and tell people this is something bigger, and it will help. All right, I'm closing my mic again. I don't see any other questions.
Well, that's impressive that this is going to Madagascar. I, again, just am very impressed and excited to see this all happening. And I want to just allow any of our participants here. We have an incredible group of participants from all over the world. And this is a wonderful opportunity to ask good questions, especially if you're being challenged by implementation of any of the 10 steps. It seems like Vicki has made it work. And yes, she does have an out-of-hospital birth center, but there are caregivers that have learned to make it work in the hospital setting as well. And Dr. Huber is one of them. And I believe there's other people here that can have seen that happen and can make it happen as well. So again, I will turn it over, Vicki, and you can answer the questions. Thanks.
Okay, I'm just reading this question about someone heard from a student who had been at our center how the midwives step right back once the baby crowns. What we're doing in second stage is we're following some of the evidence-based practices that Dr. Michelle O'Donnell has written about, of trying to keep second stage very, very quiet and dim lights and the mother not feeling observed but feeling safe, so that her neocortex of her front part of her brain will close down and birth will become much easier. And apparently, way before he identified it, another anthropologist had identified this fetal ejection reflex, where the mother just really doesn't have a second stage, just feels this kind of shift into pushing, and then the baby just flies out. So we're actually going for that. We're trying for that, and we're seeing it a lot because we are not disturbing the woman when she gets close to the end of birth. When she feels an urge to push, we don't make a lot of noise or jangle things. We don't do an internal exam if it's not a first-time mother and everything seems normal. And we are seeing babies coming out very, very quickly without much second stage. It is true that we are present and we're ready with emergency equipment if we need it, but we don't actually, I said this earlier, we don't touch the mother. We don't try to prevent tears. We don't tell her to push or not push. We just let her do it. So we are standing by, very aware of what's going on, but not interrupting. So I hope that answers your question. Once the baby crowns and comes out onto the bed, or if she's squatting onto the clean, mat, then one of the national midwives in her own language will tell her, now you can pick up the baby. So again, that's what we're going for, is these very natural second stages, the mother giving birth and then picking up her own baby. And there's good pictures of doing this in that old movie, the birth in the squatting position. They show the mother just giving birth with no one holding her perineum and just letting her give birth. So that's what we're doing to answer that question. But we're very aware. It's not the same as not being in the room or being aware. If the baby gets stuck at the shoulders, if there's a tight cord, if there's anything wrong, of course we're going to jump right in. And if the baby needs to be resuscitated, of course we don't wait at all. But in normal births, we are just standing back and letting the baby go. Where do you find time to research everything so thoroughly while running a birth center? Well, it's our passion, and I have help in all this. We have a whole family that are very good researchers, so I want to give a shout out to my husband, Scott. He is not a midwife, but he helps keep everything together with infrastructure, and he also is an amazing researcher. He pumps research my way. I also have a son and daughter-in-law that are midwives that are as passionate about evidence-based research as I am. So we're constantly doing that. And we made a decision 30 years ago when we started to always keep good stats, and that has been a wonderful decision. So we have kept incredibly good records and kept very good data on every single birth we have of over 12,000 now. And that database helps us make decisions and look at things. And we're always running studies of some sort. We'll just always say, let's study that. Let's do a third. We're in the third stage study right now. We're always picking something and just saying, okay, we're going to keep track of this. All right, let's see, what other questions do I have? Birthing centers and MBnet. Yeah. Right, we weren't a demo site because we started out doing the 10 steps. I'm not sure the global data. Again, our statistics are in birth models that work. Is that what you mean, just our outcomes? I do know that in our outcomes, and we don't always say this a lot because we don't want to shame anybody locally, but our outcomes for neonatal deaths is about 4 times lower than the country that we're in. So we know we're having very, very good outcomes. Our maternal death rate, when adjusted, is 8 times lower. All right, any more questions? Anybody have any more? I'll turn off my mic for a minute. Funding. I see the question of funding. We fund 2 ways. One is donations. We're a nonprofit organization, so we can take donations. We don't have any big funders. I wish we did. We have a lot of grassroots families that just send $50 a month maybe, and we teach midwifery. So Ian, Rose, and I are all professors on the side, and we teach. We have interns come. We have a paid internship program, and we come back to the States once or twice a year and do workshops and run a distance program for midwifery education. And we keep our hand into midwifery education in North America, as well as accepting interns into our site over there, and that helps pay for it. Okay, I see Dr. Huber is saying he has to go. Thank you very much for attending. And do women pay for services? No, never. We are taking care of women that are the poorest of the poor. So no, we do not charge anything. I said that in the beginning, but maybe someone came in late. So all the care is free. And again, we looked at the evidence for that, and we've read every side of development as well as relief, and have decided that maternity care, in order to really shift the horrible numbers of maternal and newborn deaths, is going to have to be free, at least till we get out of this crisis that we're in right now, where so many women and babies are dying in childbirth. So we figure out a way to fund it creatively other than charging fees. We do pay our national midwives a good salary, but our foreign midwives are all volunteer and get their funding from other sources. Okay, is there any other questions? Okay, I'll turn off my mic for a minute.
Again, thank you, Vicki. I want to turn the mic over to Len and or Christiane or Julie so that they can mention a lot of work that they have done about implementing the 10 steps into a hospital, and we will be having a webinar on that soon. So Alain, please share, or Christiane, share a little bit about that, please. Thank you. I don't know where Alain, I hope you pick up the mic in just a moment here. I wanted to address Celine's question here. Is there any hospital considering IMBCI? Oh, yes. And that's why we do have our demonstration sites, and those demonstration sites are in our project of implementing the 10 steps to the IMBCI. And Canada, like I said, Dr. Huber, who just left the session, they're one of them, and then our Canadian site. So I will, actually, Ellen's asking me to repeat the question. The the question for you, Helen, is if you would please speak on behalf of Christiane and mention some of the work that they're doing to implement the 10 steps, and about our future session on what they have documented so far. And now I'll turn it over. Thank you.
Hello, this is Hélène. Yeah, well, I would prefer Christiane or Julie from Quebec, the Quebec side, to do it if they want. So I'll wait until they do it. But regarding the IMBCI demo sites, there was a plan to, we accepted a site from Manila in the Philippines as a demonstration site. But it's a huge hospital, quite crowded, where about 20-something thousand women a year give birth. So there has not been any implantation there, sadly, since it started to be accepted by IMBCO. So, but your birthing center in Manila, and then the presentation you just did is an incredible example of what can be done in the Philippines. So, thank you very much. So I'll wait until to see if Judy from Quebec wants to talk about just a bit about what's happening in Quebec, because Quebec has really done a lot of work, the Quebec demonstration site, in preparing for implementing IMBCI. And the other thing that we are planning to do, but I don't want to say it before Christiane says it, is we would like very much this year in a couple of the next webinars to present what Quebec has done in order to prepare for implementing IMBCI.
I see that Christiane has written a text here saying that they will present to us soon, and they are anxious to share their experience. And what they have done at the moment, or what they're doing at the moment, is modifying their prenatal classes to sensitize the women to physiologic birth. And So it looks like some really good stuff is being done. All right, I will turn the mic over. Ellen, maybe you can elaborate on this since you are there.
Well, there's been a lot of things because we sent a questionnaire on implementation to the demonstration sites, and in the Quebec site, I don't have it in front of me, but it's a concerted effort, not only at the hospital level, but from the global structure that includes the hospital and includes local community health centers to implement IMBCI. So this effort goes in several directions, and they just changed their prenatal classes in order to have an approach more centered on the physiology of birth, in order for women to be informed and expect that approach when they give birth. And there's all sorts of things that are going to be done. But what I want to stress out is it's really everybody. As for baby friendly, everybody has to be sensitized to IMBCI. You know, for baby friendly, what they did, because even in old people health facilities, they have done breastfeeding sensitization, because grandmothers are there and grandmothers can support breastfeeding. So it's an effort to reach everyone in the community about a project, and the project will be advertised, and it will be on the walls, and it will be talked about in the community. So even in our healthcare system, which is very organized and very structured, and but it shows that it's not an isolated effort that will do something. It's really a global approach to it.
Yes, this is Ray, your session manager, and this session has been recorded, and we will get the link. PAHO, the Pan American Health Organization, is the sponsor of this opportunity for us to communicate through this webinar, and thanks to our advisor, our former executive director, Dr. Rodolfo Gomez, and he has made this available for us, so we want to thank him for that. And he was unable to join us today, but he will have the opportunity to listen in the recording. I will get a link, and I will send you the link of the recording so that you can have it as well. And Vicki, you had mentioned that your husband was the tech guy, or your son, and so I think what someone might be asking is permission to use your slideshow. Is that possible? And if so, we can. You can go ahead and put it in Dropbox if you want, or I can put it in Dropbox and they can use it that way. So yes, I see you are responding. So good. Oh, you can post it on your website too. Okay, perfect. Thank you, Scott, and everybody for being there. We're so grateful for your technology as well. Wonderful. Thank you. Now, once again, Elena, I'm going to turn this over to you if you have any last-minute announcements, and unless somebody else has any other questions. I think that we've actually had an incredible session, and so I will turn it over in case there's any last-minute questions.
Hello again. No, we'll keep you posted about the webinars that are going to come, and we'll give you the link in advance also. I just wanted to see if Céline would like to talk about the document that she just wrote, and that in Quebec they did that to have a common base knowledge about physiological birth, and so it's for all the caregivers to read, and they're in the final stage of finishing it, And so because in French anyway, there hasn't been much written on physiology of birth. A couple of books in English exist, not tons, but so it's very good idea to have done that.
Yes. Okay. Listen, I wrote it because I was working with Christiane and Julie in Cornville in Quebec, and we were trying to find a common knowledge. I just make a documentation from midwifery knowledge, most of it, and the work from Sue Down and Dennis Walsh, and so I put that together, and inspiring also from other discipline knowledge about bringing a child into the world, which was not just physiology as a biological explanation and understanding of the hormones and the mechanical and all that, but it was trying to put together how much physiology is embedded in a culture, in the environment where a woman is bringing her child into the world, and so everything is counting. It's bringing together a kind of organic or ecological way of looking at things. So it's bringing and holding together different aspects of birth, and so the people who are involved in that around birth in the hospital where there's the demonstration project in Cowansville. So it's like consciousness raising, about other elements that is not just about management of the labor and birth. So I hope it will inspire and help to bring changes, and it's just part of the all the things that are done and will be done in this hospital, because all the nurses, they are learning a lot of things. What do you do, to help a woman having a labor without an epidural, which is quite common in Quebec, the level of epidural. How do you manage, rupture membranes or different aspects of what we are used to do. So it's just looking at the glass half full and not the glass half empty. I hope it's just make a perspective of the physiology and not the potential of pathology. So it's just a point, but Hélène was saying that there was nothing in French really getting together all this knowledge. So it's bring back to the basis, but and then to the basis of the human things. I don't know if Julie or Christiane want to add something on that.
This is Ray. Would you please, I'm sorry, if you could introduce yourself, the last person who just spoke. Thank you, because for some reason it's not showing up. It showed up as Christiane speaking. And so please just clarify that. Thank you. Okay, thank you, Celine. It was you talking. Thank you. And that was my suspicion. And yes, I am sure that somebody's thinking, is there any way we can get this document? While the texting discussion is going on, I wanted to close the recording session at this time so that we can have a really good session and not have a lot of blank time when people are listening to it. They will be able to read the text. So I'm going to stop the recording at this moment, and you all may continue to text and even communicate with one another. But just like I said, I'm ending the recording at this moment. So I will keep the mic open.
Recording stopped.
So as you can all see here, Christiane will be doing a presentation on this from the Quebec site. So it'll be available, I believe, sometime in the very near future. So we will be working on setting a date for that and obviously let you all know. And we especially want to, again, thank Vicki and her staff and her family for an absolutely wonderful, impressive presentation, and for opening up our eyes to possibilities, especially in the environment in which you have to work. So again, thank you very much. And I see that there are people signing off. And so again, this is Ray Davies. So I want to thank you on behalf of our board of directors for participating today and for everything you do to promote optimal maternity care. And again, thank you for Mercy in Action for putting it to work and for demonstrating it for us. Thank you.